Hello everyone, my name is Dr. Kajaruban Kasinathan. I am a diagnostic medical sonographer and instructor. In this video, I will explain carotid artery ultrasound scanning techniques, Doppler patterns, and stenosis assessment in a clear and practical way based on real clinical experience. Carotid artery ultrasound is a non-invasive vascular examination used to evaluate extracranial cerebrovascular disease, detect atherosclerotic plaque, and assess the severity of carotid artery stenosis using B-mode imaging, color Doppler. The examination begins with proper patient positioning, with the patient supine, the neck slightly extended, and the head turned away from the side being examined. A high-frequency linear transducer is used, and scanning is performed in a standardized, sequential protocol. The study starts at the proximal common carotid artery, where B-mode imaging is obtained in transverse and longitudinal planes to assess vessel diameter, wall morphology, and intima media thickness, followed by color Doppler and spectral Doppler to record baseline flow and velocities. The transducer is then moved to the mid and distal common carotid artery, repeating B-mode, color, and Doppler at each level. The distal common carotid artery is the preferred site for intima media thickness measurement, which is normally less than 1 millimeter. The common carotid artery typically demonstrates a low-resistance Doppler waveform with continuous forward diastolic flow and a peak systolic velocity of less than 125 centimeters per second. From the distal common carotid artery, scanning proceeds to the carotid bulb, the most common site of plaque formation due to flow turbulence. At the bulb, careful B-mode evaluation is essential to assess plaque morphology, followed by color Doppler and spectral Doppler to identify turbulence and velocity changes. The internal carotid artery is then evaluated at the PR. Internal carotid artery is then evaluated at the proximal, mid, and distal segments using B-mode, color Doppler, and spectral Doppler. The internal carotid artery normally demonstrates a low-resistance waveform with high diastolic flow reflecting cerebral perfusion. Mild stenosis, less than 50%, typically shows mild spectral broadening with minimal velocity elevation, while moderate stenosis demonstrates peak systolic velocities between 125 and 230 centimeters per second. Severe stenosis is characterized by peak systolic velocity greater than 230 centimeters per second with elevated end diastolic velocity. Near occlusion may present with a markedly narrowed lumen and reduced velocities, requiring correlation with B-mode and color Doppler findings, while complete occlusion is confirmed by the absence of color and spectral Doppler flow despite optimized settings. The external carotid artery is identified by its smaller size, branching pattern, and high-resistance Doppler waveform with minimal diastolic flow, and the temporal tap maneuver may be used for confirmation. Vertebral arteries are evaluated bilaterally to confirm patency, antegrade flow, and low-resistance waveforms, while subclavian arteries are examined when clinically indicated. Throughout the examination, Doppler angle correction is maintained at 60 degrees or less. The sample volume is centered within the vessel lumen, and consistent documentation of B-mode, color Doppler, and spectral Doppler at each segment ensures accurate interpretation. Thank you very much for watching. Please keep watching, like, and subscribe to my channel, KJ Ultrasound Scanning Tips and Tricks, for more educational ultrasound content.